Good evening, everyone, and welcome to OrthoNorCal online CME course. We would like to thank everyone for joining us today. My name is Aliyah Rutunov, and I will be the moderator for this evening. I'm going to start with some disclosures and important information from the doctor's company, which will walk you through the process of obtaining your CME credits after the course. I will share my screen in a moment. And see. So this slide is walking you through the process of obtaining your CME credits after this presentation. And this will be emailed to all the participants via email late today or tomorrow morning. And then let's see, we have. I'll just wait a couple of minutes for everyone to read through. If again, you don't have to read through entirely, as the information will be emailed to everyone. Learning objectives for today's course and action statements. Great, I will unshare my screen, and without any further ado, I would like to introduce our first panelist, Dr. Tina Malamfi. Welcome, Dr. Malamfi.
Thank you. I am sharing my screen. There we go.
Perfect.
Thank you all for attending this evening. It's a nice, warm, sunny evening in California here. So today we're going to speak about low back pain, and when it's not necessarily mechanical anymore, what shall we do? So just a few statistics to go over first is that a lot of people over their lifetime, 75 to 95% of people are going to have some low back pain during their lifespan. 90% of acute low back pain resolves over the first 4 weeks. Sometimes the pain is so intense, however, that they cannot function. And there are some rule changes in the future coming up, hopefully that we can get epidurals and things authorized sooner for those people that are desperate. Surgery shortens the period of disability, but does not necessarily improve the outcome. Other statistics are that low back pain makes up 10% of the workers' comp injuries and about 80% of the cost. That number is surprising. 5% of people with low back pain make up about 90% of healthcare costs, of low back pain costs. 30% of patients over the age of 65 with osteoporosis will experience a compression fracture at some time in the rest of their lifespan. So with that, let's go on and review what the anatomy of the spine is. Here's an MRI. On the left is your sagittals, on the right's your axial cuts. Obviously your abdominal contents are up here, dorsal fat is back here. These are your vertebra, your discs are in between the vertebra, your spinal canal is in through here. Just a reminder that your spinal cord does end just below your rib cage around T1 to T2 region. Always look for that conus in your sagittal views. Over here on the right side, this is an axial cut. So it's cutting you basically through your belly button all the way through to your back. So up front here is your intestinal regions. In the back here is your skin. I've labeled here, this is your disc. This is your spinal sac of nerves where they live. Each one of these little dots represents a nerve root. Your foramina are flipped. When you're looking at these, think of that looking at the patient from the feet up. So this is your right side and this is your left foramina. Your facet joints lie right about in through here. We're gonna have a better image later on. So let's talk about pain generators in the back. There is obviously the disc. There are joints in the back. Nerve root compression, SI joint, which sacroiliac joint is one of the largest joints in the body. There's modic changes. That's where the disc meets the bone, the vertebral body. Then we have spinal stenosis, incredibly common in our populace that we see. as well as compression fractures. So let's talk a little bit about discogenic pain. Obviously, MRI, if you MRI 100 people over the age of 30, you're going to most likely see an abnormal disc at some level. That does not necessarily mean it is the source of their pain. But anyway, here's a disc. Obviously, you can see some of those are called Schmorl nodes going on there. Disc pain increases with sitting, coughing, sneezing, and bending forward. Mechanism of injury is bending forward and lifting something or twisting. Here's an example of annular tears. You will see those on the MRI reports. There are 4 different grades of tears. The outer portion of the annulus, the disc, is highly, highly innervated with pain cells. So, you know, when you sneeze and your back seizes up, that could just be a little micro tear in that annulus, and that causes a lot of axial back pain or just low back pain. Then we have facet. The facet joint, here again is another MRI. This is a better image of what facet arthritis looks like. It is an overgrowth of the bone there. It takes decades for your body to lay down more bone that is visual seen. So in my 50-year-olds, I might suspect that they have facet joint pain, but I'm not going to see a whole lot of arthritis in their joint because they haven't lived enough decades. Joint pain, facet pain in the back, increases with standing, increases with arching backwards. It's a very common site of arthritis. Often if I think someone has arthritis in their spine, I'll look at their hands to see if they have a lot of arthritis going on there. They may even have, I said before, a normal looking MRI, but still have facet mediated pain. So how do you get to the correct diagnosis of what's going on in somebody? History, 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 and physical exam. Very, very important. An EMG nerve conduction study is an extension of my physical exam. X-rays, that will help tell me if they have what's called spondylolisthesis, we're going to go over that later, or arthritis or degenerative disc disease. MRI shows our soft tissue. CT scan is going to show us more bony abnormalities, but does give me an idea what's going on inside that central canal. Medial branch blocks, that's a diagnostic only test to diagnose facet joint pain. We're going to go over that. SI joint injections, that's often ordered by my surgeons to help them figure out what's going on. All right, let's go over exam findings. This is critical. You must know, in order for a good exam, what root goes where and the sensory. So your L2 nerve root out of the back goes to your hip flexors. So I'll have the patient seated and I put resistance as they lift their knee up into the air. Their inguinal area has that L2 dermatome. L3, also hip flexion, a little bit of adduction there going on, and a little bit of knee extensors in your quads. Patellar reflex and medial thigh is where your sensory is. L4, that's your knee extensor. That's definitely your patellar reflex. And that L4 dermatome wraps around the medial aspect of the knee and into the inner aspect of the ankle. L5, that's dorsiflexion of the foot. Often I have patients walk on their heels and see if they have what they call foot drop. That L5 reflex is medial hamstring. It's very hard to get, even in someone who is skilled. Sometimes it's just impossible to get. Your first dorsal web space, that's the skin between your first and your second toe. That's where that L5 nerve root comes out for sensation. S1 is your plantar flexure. So I have patients walk on their toes. Often I'll say, stand on that right foot and give me 10 or 20, depending how athletic they are, toe raises, and then do your other side. Is there a difference? The reflex is your Achilles, and the sensory goes to your lateral side of your foot. Physical exam signs for neural tension. You've got straight leg raise, which is everybody knows is supine, and raising it up to 60%. If they have pain that goes below their knee, that could be a positive sign. It's not super sensitive, but it is one of the findings we look for. Slump test, that's demonstrated over here on the right side where the patient is seated, their leg comes forward and you bend their head forward. Femoral stretch test is when they're lying face down on the table, you bend their knee to 90 degrees and you stretch that hip flexor. If they have pain that reproduces in the anterior thigh, you can suspect L3 or L4. I put a copy here of an EMG nerve conduction study. That was one of my patients. It's quite busy with all the data there, but primarily you're going to look for the conclusion. For me, it helps isolate which nerve is the source of the pain. It also quantifies the injury so the doctor can know how aggressive or passive to treat that patient. Now, spondylolisthesis, that's a long word for slippage. That's where x-rays really, really come in handy for me and my surgeons. If you get a plain x-ray, if someone has a lot of back pain and they're not getting better with conservative therapy, such as physical therapy, you can consider getting a plain film. If you see this where they're not lined up, see how this cube jumps back to get to the next one? That is a grade 1 spondylolisthesis. If it goes halfway slippage, oh, this one's almost a halfway, that's a grade 2. A grade 3 is 3/4, grade 4 is all the way off, and that's a medical emergency, essentially. Over here on the right is an MRI with somebody with a spondylolisthesis. And what that often does is it unroofs the disc behind here, and that disc can cause some lateral recess narrowing on the MRI as well. Under the age of 40, you think of it as an isthmic spondylolisthesis, and over the age of 40, it's often degenerative caused. Here's another example of an x-ray of a compression fracture. This is one of my patients here. He's got chronic thoracic back pain because of this, not because of the compression fracture, but actually due to the mechanical forces on that facet joint being altered. The other thing I like to look for on x-rays are transitional segments. They say the incidence is about 13 to 15%, but I will tell you in my clinic, I probably see it in the higher 20s because A, they can cause scoliosis, and B, altered mechanic on the facet joints. So let's do these transitional briefly. It's that last segment where the lumbar spine connects to the sacrum, where that transverse process, normal, does not articulate with the sacrum. But in some instances, they can articulate or fully fuse. Here's an articulation going on here. And this one down here has a fully fused segment or bilaterally fully fused. That causes above the L5 problem, disc problem. Males are more common than females, and when it's unilaterally, it's most often left side more than right. Let's talk about the MRI. MRI shows us the soft tissue. CT shows us the bony anatomy, and it is mandatory before any intervention that I do, certainly before any surgeons do, and I need one at least every 2 years so that I don't miss any pathology. There's a high rate of false positives on these MRIs, which is why I say to my patients that I treat you and not my picture. Your annular tear is only 88% sensitive, so if you see one, you can be fairly certain it is due to that disc problem if the pain is solely axial. Let's talk about nerve root impingement. So a lot of the times you're looking for that central disc herniation on an MRI, such as one of these guys. Well, you can see on this MRI is that nerve root is displaced. It is compressed backwards. I will tell you most commonly, what we see is a disc herniation over here. And this section over here in this triangle in this corner is called the lateral recess. And a lot of physicians will miss that. If you're looking at your own MRIs, it's really critical that you look in what we call this lateral recess. The nerve roots can be impinged by torn discs, arthritis of the facet joint, as well as a chemical irritation. Let's talk about some minimally invasive procedures you can do. There's the epidural steroid injection. There's also facet joint treatments. That's called medial branch blocks. We're going to talk about that as well as steroids. There's radiofrequency ablation, which is a heat to the nerves that go to the joints. And then there's the SI joint injection or ablation. So epidural steroid injection. Here it is. There's an example of one. The transforaminal approach is the most commonly used down here in the lumbar spine. It goes into the hole where the nerve exits out. This is a perfect dye flow of that contrast going into the central canal underneath that's your pedicle right there. The translaminar is when you go in between the vertebra and you use a loss of resistance. I do this technique in the cervical spine. Some people do the transforaminal in the cervical spine. It's just a matter of how you're taught. Medial branch blocks. This is these started about 14, 15 years ago. Instead of doing steroid injections into the joints, as we know, steroid injections will only last a few months if we're lucky for an arthritic joint. So we were kind of forced to start doing what are called medial branches. This is where I numb, I put in my numbing needle right there, and I put numbing medication, and then I give the patient a pain chart to go home with. They don't know which pain medicine or numbing medicine they were given. They don't know how long it's going to last. They must give me back that pain chart within 2 days, and they must show at least 85% relief in order to go on to the next step. The next step is repeating the same procedure, medial branch blocks, but using a different anesthetic. Once again, they have to get more than 80% relief to qualify for what's called radiofrequency ablation. Let's talk about that. It's a procedure where we basically denervate, or we heat that little nerve root to 85 degrees Celsius. That's 175 degrees Fahrenheit-ish. We basically heat that nerve, it ablates it, destroys it. It does grow back. That nerve takes on average 11 months to regrow, sometimes up to 18 months. Then there's the SI joint injections. Here's a great example. This is one of my patients that was fused and had the other joint to it, became arthritic. We can put a needle in that joint and watch, that's the contrast dye, going up that joint. And I can put either just anesthetic, or I can put anesthetic or just steroids, whatever the surgeon wants, or if I see the patient, I decide. So that's about it. I say treat your patient's symptoms and exam, and not necessarily the images. And when you're in doubt, please, please, please get a consult. Thank you. I'm going to unshare my screen here.
Yes, please unshare your screen so our next panelist shares. Here's one thing I failed to mention in the beginning, that we will have Q&A session at the end of all presentations. Our physicians will address those questions. Please direct those to us by using Q&A button on the bottom of your screen. You can direct those questions to all panelists, and like I said, they will be addressed at the end of all 4 presentations. The screen is frozen, Dr. Malamfi.
I'm trying to, is that not working?
No.
Stop video.
One thing we can do is you can leave and then rejoin again. Maybe that will help.
Okay.
Oh, there you go.
Okay.
Perfect. Welcome, Dr. Nuzzo.
Thank you, Leah. You can see my screen?
Yes, we can see your screen.
Okay.
Great.
Hi, my name's Dr. Michael Nuzzo. I'm an orthopedic surgeon, and I specialize in sports medicine. Today I'm going to talk about hip arthroscopy, the procedure, and some of the indications and what its capabilities are, and when to refer to an orthopedic surgeon to consider hip arthroscopy. So hip arthroscopy is sometimes called the final frontier of sports medicine. It's one of the fastest growing procedures in sports medicine. And a lot of that has to do with the new technology that's come along that helps us not only diagnose, but treat some of the pathology in the hip. And so it's specialized instrumentation that's different than the arthroscopies we perform in shoulders or knees or ankles. So as I said, there's been such growth in hip arthroscopies over the last decade or so. Again, due to our better understanding of the biomechanics of the hip and some of the pathology that causes hip pain, and then the advancement in the surgical instrumentation. Hip labrum tears or hip pathology in general is often overlooked. This is a study by Burnett in the Journal of Bone and Joint Surgery in 2006. I think this has improved over time, but this was an average time from injury to accurate diagnosis was 21 months. And, average of 3.3 providers seen before definitive treatment. And this is pretty consistent with my experience. A lot of times it's misdiagnosed as lumbar back pain or groin pulls or even hernias. So there's a laundry list of differential diagnoses for anterior hip pain. Dr. Malumfi talked about many of these that originate from the lumbar spine. And you can see a long list. I'm not going to go through all of them, but it can be a very confusing picture when you have a patient that complains of hip pain. But what I can say is that if you have chronic groin pain, that is pain that's localized to the groin region of the hip in a younger to middle-aged patient, then 85% of those is going to be caused by some labrum pathology, usually a tear. So the focus of today's discussion will be the evaluation and treatment of a condition called femoral acetabular impingement, which goes along closely with labrum tearing and also cartilage injuries in the hip. And then I'll show a case example. So what is femoral acetabular impingement? It's a long, complex words or diagnosis. It's essentially just the bones of the hip impinging upon each other. And it's caused by the shape of the hip bones. This is something that people are born with. It's genetic. It's just a natural shape of the hip. And many people have this kind of impingement, but don't have pain, don't have labrum tears. But it tends to show up in more athletically prone people or younger people who work their hip more vigorously. It's really common in certain types of sports like hockey, and soccer and basketball, where they're used aggressively in sport. So there's three types of femoral acetabular impingement. There's a CAM type, there's a pincer type, and then there's a combined type. The CAM describes extra bone on the femoral head and neck. The pincer type describes overlap of the acetabular bone that creates the impingement, and then you can have a mixed or a combined type of femoral acetabular impingement. The CAM draws its name from the definition of a CAM, which is a projection on a rotating part. And you can see the arrow that points to the protuberance of the femoral head and neck junction. This typically is more rounded in patients that don't have femoral acetabular impingement. And CAM type is by far the most common impingement we see. So this is essentially a cartoon that shows how this CAM can create the pathology we're talking about. So this is the femoral head here. This is the acetabulum. This green part represents the labrum. And then in this section, you'll see the cartilage. And as that CAM rotates up into the labrum, you see how it presses on the labrum and the superior cartilage of the acetabulum. And over time, it creates a tear and it creates damage to the cartilage. And this is clinical pictures of what that represents. On the left here is a tear in the labrum. And we'll get into what the labrum is and the cartilage damage that can also come along with that from the impingement. So the labrum serves an important function. It helps distribute load and decreases contact stresses on the articular surface and enhances stability, provides a seal for the joint to maintain the synovial fluid pressure. The labrum is a gasket that surrounds the cup of the acetabulum that's mostly a collagen structure, type 2 collagen. So when assessing a patient, patients usually describe a pinch in the hip joint with mechanical symptoms like popping or clicking. It usually demonstrates loss of flexion and internal rotation from the CAM impingement. And patients often have pain with prolonged sitting or rotational movements like getting in and out of a car. On exam, patients often describe their pain using the C sign, where they grab the side of their hip and their hand is cupped around the hip, localized to the groin. The pain tends to be distributed from anterior to posterior, and oftentimes this is misinterpreted as a lateral hip pain involving the gluteus medius or the trochanteric bursa, but this is a very common sign that you want to look for, especially in young people. On physical exam, the anterior impingement test is the most specific for impingement or labrum tears. So it's when you flex the hip up and then internally rotate the hip, and that's fairly specific. It's the most specific exam we have to diagnose hip impingement and/or labrum tear. Trochanteric bursitis and gluteal symptoms, they tend to be more laterally focused, and patients tend to have more point tenderness to the outside of the hip. My son just walked in and is grabbing some food off the table. You can also do the abduction test, or you see on the right here, which you bring the leg off the table, and that will also oftentimes create more pain in the lateral hip, pointing more towards gluteus medius tendinitis or trochanteric bursitis. So imaging, standard imaging or radiographs, AP and lateral views of the hip. These are some of the measurements that can be performed when looking for pathology on a hip x-ray. The center edge angle, looking for developmental dysplasia of the hip with a normal angle being normal being greater than 25 degrees, a crossover sign. Often we use the alpha angle, which is a measurement for the CAM severity. And the greater the alpha angle, the larger the CAM lesion. Again, this is just drilling down on the alpha angle. Anything greater than 55 degrees is considered abnormal. So you can see here that when you're measuring the alpha angle, anything that falls outside the circle at something greater than 55, or sorry, a degree greater than 55 degrees is considered abnormal, and is diagnosed as CAM type femoral acetabular impingement. So MRI arthrograms are the gold standard to diagnose a tear in the labrum. These are two MRIs, and the arrows are pointing to a superior and anterior labrum tear. You can see in this MRI the large CAM lesion associated with it. So treatment involves repairing the labrum tear, also different regenerative procedures, abrasion chondroplasty or microfracture for areas of chondral damage where there's full thickness loss. And then trying to diminish or remove the impingement, whether that be a osteoplasty of the femoral head and neck, or femoroplasty, or an acetabuloplasty for a pincer type lesion. You want to debride down the bone to try to prevent the impingement from recurring and protect the repair. So the femoroplasty, the idea is to create a more rounded head. You can see here, this is pre-femoroplasty, and then after, this is just a cadaveric model to show what we can perform when we're doing a femoroplasty to create a more rounded shape to the head. The surgical technique, again, it's arthroscopy is done with a camera, and it's done through small incisions or portal incisions, usually 2 on the anterior and lateral side of the hip. So this is a case example. It's a 17-year-old female gymnast athlete who had been complaining of chronic left hip pain. She had an alpha angle of about 55 degrees. The MRI demonstrated some delamination of the superior cartilage with a tear through the superior labrum. This is just the first picture of the procedure. We entered the hip using fluoroscopic guidance and an air arthrogram. And the hip is pulled into a distracted position during the surgical procedure to allow us to work within the hip joint. And this is demonstrating the hip in that distracted position. So this video is showing some of the tearing. This is called the wave sign. This is loose cartilage here, and we'll show that in more detail here. See here, you can see that some of that delaminated cartilage that was loose, and this is the labrum here. This structure, and we're cleaning up some of that loose cartilage with this shaver device. Once we remove the loose cartilage, then we perform a regenerative procedure on the area where it was delaminated from, and then also you'll see we perform the repair of the labrum. So this is after the loose cartilage was removed, and this structure that's being probed is the labrum itself. You can see the circumferential nature of the labrum and how it's detached from the underlying bone, and probes coming through and under the labrum and through the tear. This is a suture anchor that's being placed in the superior acetabular bone. And the sutures attached to that anchor are then passed around the labrum with a suture passer. And then this is a demonstration of a repair of the labrum tear. A couple anchors reattaching the labrum, anchoring back into the superior acetabular rim. And this is a procedure called a microfracture, where we tap holes into the subchondral bone where the full thickness cartilage defect was, in order to get down to some of the stem cells in the bone marrow, to allow those to come up and help regenerate and form a different type of cartilage called fibrocartilage. And this is after our microfracture procedure and the final product of our labrum repair. And this is the femoroplasty part of the procedure, where we are debriding or removing some of the impinging bone. And this is sort of a final picture where this is where the cam lesion used to be. This is contoured bone to create a more spherical femoral head. And this is the superior labrum tear repair. So outcomes of hip arthroscopy are in general excellent. This is a study performed by Dr. Philippon, where he performed this procedure on 45 professional athletes, and 93% of those athletes returned to professional competition. So it's a fairly satisfying procedure to do. It has a lot of success. For that reason, I enjoy doing it. And thank you.
Thank you, Dr. Nuzzo. I'm going to ask you to unshare your screen so our next participant can share theirs. And I would like to welcome our next panelist, Dr. Jeffrey Blue. Welcome, Dr. Blue.
Great, thanks, Leah. Make sure you guys can see my screen. Is that working?
Your screen works perfectly.
Okay, great. Hi, I'm Dr. Jeffrey Blue, and I practice family medicine and sports medicine here at OrthoNorCal. My talk today will be about when to refer to these other people I'm discussing with today, orthopedic surgeons and Dr. Lumpy also as well. Let me make sure this works here. Okay, so I have to click. Our goals today are to improve your differential diagnosis for common sports injuries. Why is this important? Well, it's important because this is why they pay you the big bucks. Anybody can surf the internet and figure out that if you roll your ankle, it's probably an ankle sprain. But what if it's not? That's why your expansive differential diagnosis is important. Also, it's important to know what you know. While more difficult, it's also important to know what you don't know. This is when it's typically time to get a referral. The more you know, the more you can manage. This talk should improve your database of knowledge to help you know when this occurs. Let me tell you quickly about my story and how I came to practice family medicine and sports medicine. When I applied to medical school, I wanted to be an orthopedic surgeon. I love playing and watching sports, and I wanted to be a team physician for a sports team. One day, the team physician for the football New York Giants was giving a lecture at our medical school. He was a family medicine doctor who specialized in sports medicine. I remember after that talk going up to him and arrogantly asking him how he could possibly be a team physician for a professional sports team, not being an orthopedic surgeon. What he said stuck with me and was the impetus for me to becoming who I am today. He said that 90% of sports injuries do not require surgery, and that if you're talented enough, you can manage all of those injuries yourself. My experience over the years tells me that it's probably a lot more than 90%. How close are you to managing 90% of the injuries you see? Hopefully today's talk will expand your knowledge base of what you feel comfortable treating, knowing better what cases need to be referred. This talk will be about 5 hours. No, it should be about 25 minutes. I may have to have my friends here cut me off if I go too long. We will work through cases I have seen in my practice through the years and hopefully learn how to manage different situations. Unfortunately, I cannot impart my entire wealth of medical knowledge to you today, or maybe I can. Well, time has started, so let's get going. So let's go to the first case here. Case number one, Steph is a 21-year-old male who 2 days ago was skateboarding on his way home one night on his college campus after having one too many drinks and did not see a small rock on the sidewalk. As his board came to an immediate stop, he was thrown forwards and fell into an outstretched right hand. He went to sleep that night, and the next day he noticed pain around the radial side of his wrist. He comes in to see you at the Student Health Center today. You examine him, and he has pain around the thenar muscle of his hand and in the anatomical snuff box. You order the appropriate x-rays, and it shows that Steph has a fracture of the scaphoid, or navicular bone. What's important about this injury? First thing to know about this injury is that when someone falls on an outstretched hand, you need to order the correct x-ray views. Throughout this talk, we'll be giving you some master points to remember. The appropriate views for a fall into an outstretched hand are AP, or front view, lateral, scaphoid, where you ulnar deviate the wrist to bring the scaphoid into view, and clenched fist. The scaphoid, which is over here, is the largest and most important of the carpal bones. It also does not like to heal. The blood flow is unusual in that it flows from more distal to more proximal. Here you can see a picture of the blood flow coming backwards into the scaphoid. And this can cause non-unions when it does fracture. Due to the blood flow, more distal fractures tend to heal better than more proximal fractures. You can probably treat distal and mid-body fractures as they tend to heal. Casting is controversial. When you move your forearm in supination and pronation, the wrist joint also moves. This can affect healing of the scaphoid. It is generally accepted practice to use a long arm cast for the first 3 to 6 weeks, and then transition to a short arm cast for 3 to 6 weeks or more. Due to slow healing, this injury may need to be casted for up to 12 weeks. As for when to refer to an orthopedic surgeon, refer the proximal lesions or fractures, and also the middle fractures that end up going on to non-union. Also, athletes tend to get surgery for this. They tend to get a screw put in to almost guarantee the healing rather than waiting for a mid-body scaphoid fracture to heal. Now let's change the case a little bit. Steph had a fall on an outstretched hand, but there was no scaphoid fracture. Dr. Blue's master points are here. Another master point, expand your differential diagnosis. Everyone can diagnose a wrist sprain, but you know all or mostly all of the other things that this can be. Again, this is why they pay you the big bucks. You need to think beyond the obvious. You were smart enough to order a clenched fist view. You can see on this view, the fingers are bent. This is a clenched fist. There's widening between the scaphoid here and lunate bones. This is also known as the Terry Thomas sign. And of course, this talk would be incomplete without a picture of Terry Thomas. So now you'll never forget scapholunate dissociation. Sorry about that. This widening between the scaphoid and lunate bones is due to a rupture of the scapholunate ligament. It is called scapholunate dissociation. Appropriate treatment for this is to splint the wrist and to refer. These need surgery. Left untreated or missed, the wrist will look like this. Scapholunate dissociation will likely result in scapholunate advanced collapse or slack wrist. This is osteoarthritis of the radioscaphoid joint, which will then progress to other parts of the wrist. A fall into an outstretched hand may also result in fractures that occur. Common fractures that occur are a Colles fracture. I think most people have seen this. This is when you fall into an outstretched hand and the distal radius will fracture. A Smith fracture is just the opposite, where you fall onto the back of your hand and that forces a fracture in the other direction. It's less common than a Colles fracture. These should always be referred. Here's some examples of the Colles fracture and Smith. Let's close this here. This is the opposite. There we go. A styloid fracture of the radius or ulna, if minimally displaced, may be treated in a splinter or cast. Displaced fracture should be referred. So if it's just a little distal tip fracture here, you probably can splint those. And these should actually heal fairly well as long as there's not a lot of joint involvement. Finally, a common fracture in children who have softer bones or green stick forearm fractures where the bone will bend. These typically heal well in a splint or cast. Some examples of green stick fractures. Now, unfortunately, Steph fell again onto his outstretched hand, but has ulnar-sided pain in his wrist. He has tenderness over the soft tissue between the ulna and carpal bones. He also has pain loading his wrist, such as doing a push-up or rotating his wrist to open doors or jars. X-rays are negative. Pain in this area with negative X-rays are often tears of the triangular fibrocartilage complex, or TFCC. The TFCC is the most important. Let me go back here. I'm skipping ahead, so I'm going to skip ahead one slide and I'll come back to you guys here. This is really exciting. There we go. TFCC sprain. My bad. TFC sprain. It's the most important complex on the ulnar side of the wrist, giving it stability. And tears of this will actually result in weakness on this side of the wrist. More common ways to injure the TFCC are when you have repetitive loads such as biking or push-ups or an acute forced rotation of the wrist. Another master point, treat this like a fracture and immobilize early in a cast or splint for 2 to 3 weeks. TFCCs, you have a quick chance to get these things to heal early. And if you can really splint these as opposed to letting them use the wrist, they tend to heal fairly well. Complete tears will likely need to be referred to an orthopedic surgeon for surgical reconstruction. And if left untreated, these often missed sprains can lead to chronic wrist pain and weakness. If a patient's not better after a few weeks of immobilization, you can order an MRI. And TFCC tears appear really well in the MRIs. You can do a standard MRI and see tears here, or you can do an arthrogram and see if there's dye that leaks out. I'm going to go backwards. If that's okay with you guys. Sorry, I'm ruining all the excitement here. Steph falls an outstretched hand, but has pain in the hypothenar area. Initial X-rays are negative. So in this case, in the hypothenar area, which is the opposite side of the thenar area, the key here is you need to order a carpal tunnel view. And this x-ray shows a fracture of the hook of the hamate. And you can see the position of the hand here when you do the x-ray. And here's the hook of the hamate coming into view here. The hamate is one of the carpal bones, has a small hook that protrudes into the palm of the hand, and a CT scan can help if the x-ray is inconclusive. Here's another view. This is a hamate fracture, hook of the hamate fracture. And again, you have to bend the wrist in a certain way to actually have that appear. It's a nice view of a CT scan. And the hook of the hamate protrudes there. This injury is more common in such things as a golfer swinging a club and hitting a root into the ground, or a baseball player hitting a ball off the end of the bat. In both of these cases, the equipment being held is being forced into the hook of the hamate and causes the fracture. All of these should be referred as the treatment is to remove the hook of the hamate. Another master point, in sports medicine, you'll see the same stories that go with certain injuries over and over in your career. Remember the stories, as these will be recurring and help you with your diagnosis. Let me go forward a couple slides here. Brilliant, okay. Once again, Steph falls onto his outstretched hand, but this time is unable to fully straighten his elbow. On exam, he has apprehension on extension. This is an uncomfortable feeling when the elbow is forcefully extended, and he has tenderness over the radial head and neck. Master point, so this should be considered a radial head or neck fracture until proven otherwise with this kind of history and this kind of exam. Radiographs can be subtle, and here they show a fracture of the radial neck. And again, this could be just a little indentation or a very small fracture. You have to look carefully at these. Negative x-rays with a high level of suspicion should have very close follow-up. You want to refer all displaced or intra-articular fractures. Sometimes the radial head will need to be removed to prevent arthritis later on. And here you can see an example of a radial head fracture that's depressed. This can have late complications. This deserves a referral. Non-displaced and non-articular fractures may be treated with a sling for comfort for 7 to 10 days, followed by early mobilization. Immobilization for longer than 7 or 10 days may result in elbow stiffness, which can be a bigger problem in the future. One last point. Don't forget about posterior elbow dislocations, as these can also result from falls onto an outstretched hand, and these should be sent to the emergency room if these occur. We're going to keep changing this case. Now, Steph falls yet again onto an outstretched hand, but this time has pain around his clavicle. A more common mechanism of injury is landing on the side of your shoulder, such as during a football tackle or fall off a bike. Radiographs should show the fracture of the clavicle. Clavicle fractures are relatively common. They are typically classified into thirds: the proximal third, middle third, and distal third. Proximal clavicle fractures are typically stable. These can be treated in a brace or sling for comfort, such as a figure of 8 brace. And just in general, master point, hopefully everybody knows this, bones take 6 weeks to heal in general. Middle third fractures used to be treated non-operatively, but recently treatment has changed to prefer the operative treatment. These should be referred now. Typical operative treatment will be putting plates on. You can see what this looks like on an x-ray. Finally, distal third fractures are complicated and treated based on exactly where the fracture is in relation to the supporting ligaments. These should typically be referred if you're not sure how to manage these. So the distal ones should be referred. We're almost done with Steph falling, I promise, but he fell once again onto his outstretched hand. but this time has pain around his acromioclavicular or AC joint. More common injury mechanisms are the same as those that cause clavicle fractures. Falls onto the point of the shoulder in football or bike crashes can cause AC joint injuries. AC joint sprains are typically graded 1, 2, or 3. There are further classifications, but beyond the scope of this talk. They're easy to remember. In grade 1 sprain, the joint is lined up. Grade 3 sprains, there's a complete dislocation. And in grade 2 sprains, there's some overlap or partial coverage. Grade 1 sprains typically heal well. Grade 2 can heal well, but can have late arthritis because the joint is not articulating correctly. And grade 3 sprains used to be treated non-surgically, but now are being treated more often. I would consider referring these over. Proper x-rays can be a clavicle x-ray, shoulder x-ray, or an AC joint x-ray. They all should show the AC sprain. You can also use weights on the AC joint x-ray. And sprains of the, so here's a grade 1, there's a grade 2 with some overlap, and finally a grade 3 sprain here. And sprains of the AC joint and fractures of the lateral third of the clavicle are treated similarly. Unfortunately, Steph falls again with his arm out and above him and onto an outstretched hand. This time he dislocates his shoulder. What's important about this injury? So shoulder dislocations can occur in different directions. Anterior dislocations, by far the most common, making up about 95% of all dislocations. These occur when your shoulder is abducted and externally rotated. This can be thought of as a throwing position when you cock your arm back to throw. This is the most unstable position for the shoulder. Posterior dislocations are much less common. These occur when your shoulder is adducted and internally rotated. Think of an offensive lineman in football with their arms out in front of them trying to block another player. Inferior dislocations are rare. Some examples of how you can dislocate your shoulder. Master point. If you're covering a game, consider reducing an acute dislocation quickly on the field, as it is much easier to do before pain and muscle spasms set in. Distract and pull downward on the shoulder. All of these should eventually be x-rayed. Proper views include AP of the shoulder, lateral, and axillary views. A good rule of thumb is the age of 20 in determining treatment. 80% of patients under 20 will re-dislocate. Those over 20 will likely do well with rehabilitation. Consider ordering an MRI to see if there is damage to the anterior joint, such as a bone injury or a labral tear, which will likely lead to further shoulder instability. Refer all high-level athletes and patients who have multiple dislocations. This will be the last time Steph falls, I promise. Steph is now 62 years old. After a lifetime of falling, he now falls again onto his outstretched hand. By now, you would think that he would know that this is not the appropriate way to fall. Learning how to fall and roll at the same time is an art form that a lot of bikers learn the hard way. Some key points. When you fall, stay bent, protect your head, land on the meat of your body, your buttocks are back, and try to roll if you can. Anyway, Steph now has shoulder pain and weakness lifting his hand away from his body. Master point. Older people get different injuries than younger people. Young people under 50 years of age typically do not tear their rotator cuff unless they are involved in high-speed trauma or are a very high-level athlete playing a throwing sport, tennis, or swimming. Older patients over 50 may have minimal trauma to an already worn down rotator cuff tendon. The tendon usually wears down and thins as we age through repetitive trauma or disuse. Remember, rotator cuff pain, when it occurs, is typically felt in the upper outer arm. Some pictures of rotator cuff tears. Who do we refer? All full rotator cuff tears and many high-grade partial tears. These may actually function as a full tear. Also, labral tears will not repair on their own and should be referred. Isolated partial tears can be rehabilitated. High-level athletes will probably get the partial tears repaired at the end of their season. Can I ask how we're doing for time?
Yes, you're good.
Leah?
Yeah, I've left
Good, okay.
more slides. Yep.
I have like 1,000 more slides, Nick, so I can go through another case if you want.
Yeah, that's okay. Go ahead. Go through one more case and then we'll.
All right. Fantastic. Case 2. Alex, the 24-year-old basketball player. She's a former college basketball player who is currently working as a software engineer at a high-tech company in Silicon Valley. She was playing in her Monday night co-ed basketball game last night, and when she was reaching for a rebound, another player struck the back of her hand, causing the tip of her finger to strike the ball. She felt pain and had swelling soon after at her distal interphalangeal joint, or DIP joint. Since then, she has noticed the inability to extend her fingertip completely. She comes to see you in your office. You notice tenderness distally over the DIP joint and weakness on extension. What is the proper workup and treatment for Alex? Alex has suffered a mallet finger injury. I think we've all seen these. This occurs when the tip of the finger is forced downward while the extensor tendon tries to contract, and this will actually snap. These two forces pull in different directions, and either the tendon snaps before its insertion into the distal phalanx, or it remains intact and pulls a piece of bone off. The patient will be unable to extend their distal interphalangeal joint against resistance. Here's a picture of a fracture. Here's a picture of the tendon. They're both mallet fingers. Professional athletes are not immune to this injury. There are other ways to do this as well. These should all be x-rayed to rule out a fracture. This is without a fracture. This is with a fracture and some retraction. So in general, fractures that involve more than 1/3 of the joint or are displaced more than a few meters should be referred. Mallet fingers without a fracture should be placed in a splint in slight extension. The splint should not be removed for 6 weeks. Now instead, Alex doesn't have a mallet finger injury, but rather a finger fracture. Fractures of the bones of the fingers are obviously noted on X-ray. In general, spiral shaft fractures should heal well. Fractures through joints involving 30% or more of the joint should be referred. So here's a spiral fracture. This could be a little tricky. This is going through the joint. This may actually be unstable. This one should be pinned. This is the distal tip. This will be unstable. Just a quick master point in general for all injuries. Remember, never get too excited about a fracture. There can be significant soft tissue injuries as well, and these should be checked for carefully. Now, instead, you notice Alex dislocated her proximal interphalangeal joint, or PIP joint, on the field. You immediately recognize it as a dislocation and note that it's much easier to relocate immediately, just like the shoulder, rather than waiting for the soft tissue spasm and swelling to occur. Typically, you would relocate this by traction and trying to pull the edge of the middle phalanx past the proximal phalanx. If you were in the office, you would first get an X-ray to confirm the dislocation. If you already relocated, you get an X-ray to confirm your successful reduction. If it was still dislocated in the office, you would recognize it this clinically as well as on the X-ray. Most likely, you would need to do a nerve block prior to relocating the joint. Afterwards, you would confirm your successful reduction with an X-ray again. Dislocations accompanied by fractures should be referred. Otherwise, dislocations can be treated with a splint. Now, changing the case a little, Alex has swelling at her PIP joint. One of her collateral ligaments has laxity on testing. X-rays are obtained and are negative for fracture. This is a finger sprain and can be treated easily. Also, small non-displaced fractures may be treated as well. Treatment usually involves buddy taping for a few weeks. And these should all heal within a few weeks. And make sure not to forget to x-ray these. You can have a fracture. A couple more injuries to Alex here coming up. Alex changed sports and was now playing flag football. After grabbing another player's shirt, she feels pain in her distal interphalangeal joint, or DIP joint. When you see her, she is unable to flex the tip of her finger. This injury is the opposite of mallet finger, and it's appropriately called jersey finger. This is not the same as Joyzy finger. Sorry, Nick. A jersey finger is a tear of the flexor digitorum profundus tendon. This flexes the tip of your finger, and you can see the tear here. These should all be x-rayed, as there can be a bony avulsion rather than a tendon tear similar to mallet finger fracture. Refer all full tears and displaced fractures. Small non-displaced fractures can be immobilized in slight flexion. Alex, truly showing her versatility, was rock climbing and felt pain and a pop in her palm and her around her long finger metacarpal phalangeal joint. In aggressive rock climbers, this is usually a tear of the A2 pulley, which supports the flexor digitorum profundus tendon. Pulleys are important on your fingers to prevent bowstringing of the tendon. They prevent tendons from sliding forward as we bend our fingers. They help give us grip strength. Pain and weakness will result if this is not repaired. Pulleys help generate mechanical force and cause weakness if they're not intact. And here's an example of the bowstring in a mechanical force diagram. These eventually should have an MRI and should be referred for surgery. A couple more here. Alice is not done destroying her finger yet. She again injured her proximal interphalangeal joint, or PIP joint, and has a boutonniere deformity. This is also known as a central slip injury. With this injury, the distal tendons will slide down and create a deformity that will be permanent unless it's repaired. You can test for this injury by placing the hand at the edge of the table and having the patient try to extend their finger against resistance. These should all be referred. Two more. Alex now injured her proximal interphalangeal joint, but this time there's tenderness over the palmar surface of the joint. This is a volar plate injury. The volar plate is the structure that supports the palmar side of the PIP joint. This is known as a common finger sprain. These should be x-rayed as they can have a bony avulsion. Treatment consists of a splint that allows flexion but limits extension to allow the volar plate to heal. Alex went skiing in her off season and fell with a ski pole in her hand. She put her hand down as she was falling with the ski pole in the palm of her hand. Her thumb had a valgus stress applied and she had pain around the first metacarpal phalangeal joint. Her pain is on the ulnar aspect and she has swelling and weakness on gripping. On exam, the ulnar collateral ligament, or UCL, has pain on stressing, but there is a good endpoint. You make the diagnosis of an ulnar collateral ligament sprain, or grade 2, or gamekeeper's thumb. What's important about this injury? First of all, these should all get x-rays as there may be a fracture. The ligament may be simply stretched, but it also can remain intact and pull a piece of bone off. Painless full opening of the thumb likely indicates a complete tear. If you're unsure, an MRI can be helpful. Full tears should be referred as the ligament may be blocked from healing. And just a master point, treat these like a fracture, just like the TFCC. Partial tears can be treated with a splint or cast, as incomplete healing can result in weakness on gripping. I think I'm going to stop there and say thank you very much for listening, and I'll turn it back over to Leah and Nick.
Thank you, Dr. Blue. I'm
my
going
screen.
to ask you to unshare your screen so Dr. Abidi can share his. And with that being said, I'd like to welcome our next panelist, Dr. Nicholas Abidi. Welcome, Dr. Abidi.
Hey, Leah, I'm going to just put my screen up here in a sec. First of all, I want to thank everybody for attending, but also thank the speakers for giving their great talks. I think we'll have a podcast developed for Dr. Blue eventually, and he'll be able to run our weekly orthopedic non-operative management techniques, which I think is phenomenal. And I would agree that what he's saying about non-operative management is true, that most of what we do see is non-operative. And that's one of the reasons why I chose to go into surgery, because I like fixing those things. Actually, I was pretty good at it. And I enjoy talking about the non-operative side, but I really like fixing things. So can you see my screen okay?
Yes, perfect.
Okay, good. So I'm going to talk about something a little bit different. I have no conflicts with this talk. I'm going to talk about why we are changing the face of orthopedics and involving things that that we're not really familiar with, but in terms of looking at medicine, not just simply looking at doing everything for everybody all the time, but actually trying to be careful with what we do and how do we get to that pathway. We have a limited number, non-infinite amount of resources available with Medicare, insurance. We have rising premiums, we have decreasing reimbursement, and the pie gets bigger and bigger for entities and for implants, but smaller and smaller for physicians. So we're trying to also lower that percentage of GDP that we're spending somewhat, or at least be responsible in our expenditures so it doesn't get taken away from us. So I'm going to talk about that with orthopedics a little bit in terms of the overall concepts economically, and then drill it down to what we can do on an inpatient basis as well as a perioperative basis to limit complications related to orthopedic surgery and create more efficient systems that we've been able to do over the past 10 years with something called co-management. So Michael Porter is a professor of economics and healthcare at Harvard, and thought that we should transfer perhaps not just quantity, but to derive to quality measures. And he used a lot of material gathered from data mining, saying that things like the US perinatal mortality rates were very high compared to the rest of the world. Some of that's true, some of that's not true, because we report our data fairly honestly, and the rest of the world doesn't always do that. And we're extremely honest compared to the way other folks report that stuff. Donald Berwick was the chairman of the Medicare at the time, and then became the director of the American Healthcare Quality Research and Quality Institution, which sort of monitors these things. He's also in the editorial board for the New England Journal of Medicine. He's a pediatrician by trade, and he's a professor at Harvard, and not really an adult physician in terms of treating adults. So I'm not sure why he became chairman of CMS, but he did. Emmanuel Ezekiel is the brother of Rahm Emanuel. So Ezekiel Emanuel, sorry, is the brother of Rahm Emanuel, and he was one of the authors of Obamacare, which looked at quality measures and tried to translate some of this theoretical stuff of Michael Porter to what we saw as the Obamacare Act. And there have been many authors in Change in Orthopedics as well, who translated the overall health philosophy to orthopedics to try to make things cleaner, improve indications, and improve outcomes while not spending more money, hopefully. And some of these things are straightforward, and it's really complicated in terms of how it's practiced. But the whole trick is we really want to be able to do this ourselves somewhat before it's done to us. So as physicians and as healthcare managers, we want to make sure we understand what fee-for-service was our pure model previously, which is kind of dwindling now. And if there's no financial risk to the doctor or the healthcare professional. And then as we slide to the right, we had bundle payment, which is where we are now for most of our large expenditure for orthopedics, total joints and spine, and then shared saving models, and then sliding on to capitation. What happens is we go from left to right here is we put the fiduciary, the financial risk, onto the healthcare team, including the physicians and the nurses in the hospital. So we're sort of in the middle right now, and we don't want to slide too far to the right. When I came to California, we were all the way over here, which was way too far. And this is slightly more reasonable, but still very difficult. And you can't just jump into this. You have to have a system in place from the minute the patient hits the front door to the post-op visits to avoid things like readmission and repeat surgeries and infections. And so if we look at this, the provider-based models are things like the shared savings accounts, shared risk, medical-centered homes, accountable care organizations. These are things which are kind of being toyed with the government. The government saved the most money in the past 2 years in orthopedics, $650 million, by instituting bundled payments. And so they're out of the 3 different demonstration models, medical home, ACO, and bundle payment model, they did the best with bundle payments. And some of that wasn't fair because they didn't really do what's something called risk adjustment. And we'll talk about that a little bit in a minute. So when you look at the key objectives of successful accountable care organizations, it's to reduce costs, deliver the best care, and improve population health. So things like diabetes, hypertension, weight loss, management techniques of that, the physicians are rewarded for that, particularly in the ACOs, but also in things like Medicare Advantage by documenting and providing some conservative care and bringing people in more frequently. It really requires a team to put this together, and there are consultants that come in, but consultants aren't really stakeholders. The physicians and the people who are locally taking care of those patients that we've signed up to take the responsibility for are really the leadership in this process. And they have to understand it and be engaged with it and not ignore it, because it's going to be mandatory by 2023 for most of our large spend dollars. And so doctors really have to be aware of this, and everybody on the healthcare team has to be aware of this. So we put together a program about 10 years ago at Dominican and also now at El Camino to standardize care, standardize pain management perioperatively, and to decrease complications. We also wanted to make people get better faster, get people out of the hospital quicker into the environment. We felt there's less infections and less complications, and improve the overall patient experience or process of care. And so we measure that with quality outcomes measures and tools as well. And we try to make it fair by making sure those tools are somewhat objectified with some risk data. So the higher risk patients that we're taking, we're not cherry picking and turning them away. We're very careful about that. And we want to make sure everybody, though, is just well documented ahead of time. The only problem is Medicare really didn't tell us how to do that. They kind of told us afterwards what they were going to do, and they changed the picture a little bit on us. So the main areas of focus we talked about a little bit, we instituted things like standardized pathways, pain management protocols, including regional anesthesia, spinals and blocks, local anesthetics, as opposed to general anesthesia. The mortality rate is lower with these treatment because when you have a spinal anesthetic or a canal block, your blood pressure is stable during surgery. It doesn't go up and down. You have less risk of stroke, and heart attack is less stressful for your body, and you get less narcotics during surgery. The people that are contraindicated have spine surgery, or they're on chronic blood thinners and they can't have a regional anesthetic sometimes. But overall, the tide for large practices has shifted. And large studies, meaning looking at 10 to 20,000 patients, show that this is very effective as regional anesthesia as much as possible. Get people out of bed the same day. We have measurement and metrics that we look at, and then pain management using multimodal pain control as opposed to narcotics. And it's been very successful getting people home rather than skilled nursing facilities, and also decreasing their length of stay. We've used management tools that are measuring their outcome administered to the patient way ahead of time on a longitudinal spectrum to see how they're doing in their own words based on qualified or validated outcomes measure techniques. And so some of that you'll see is actually something called process of care, where we ask them how the room was it warm, how's the environment, but then also we also want to know how they're doing functionally. And this is something that Medicare hasn't really emphasized enough, is that how'd you do? How did it affect your life? Where did you go from where to where? And we'll talk about that in a little bit. So when you look at the American Society for Anesthesia classification system, this helps us figure out who a healthy patient is. They're ASA1. Someone with mild systemic disease, ASA2. ASA3 has more severe disease, but is not incapacitating. And people above that level are pretty sick. They have unstable medical conditions, or they're perimortal. They're going to die. And so we look at this ASA classification, and I tried to use this nationally for risk adjustment and comorbidity calculations, but it's a little bit too broad. When you look at statistics, it's a little too vague. However, when you look at inter-observer and intra-observer variability, it's highly consistent. People actually are able to rank these patients consistently when you give them an objective question, and it's still a good measurement. So we use these in some of our studies as well. When we looked at patients' issues, there's a whole variety of things. I'm not going to go through all of them, but these are major risk factors for orthopedic surgery. They're not contraindications, but they're major risk factors. And we kind of want to narrow things down a little bit. The things that were the most heavily weighted are things like catastrophic thinking, diabetes that's not well controlled, dialysis, which is a contraindication to joint replacement surgery or big surgeries, hepatitis C that's untreated, and chronic narcotic use, and also patients who have had previous surgeries and large deformities or risk of infection previously. Those are patients that have a hard time recovering from surgeries postoperatively. The things that we've looked at that weren't on that list also was things like family support, the facility where it's involved. Are they doing enough procedures? Is there an orthopedic team, which we've assembled in all of our facilities for consistency? Do the patients engage pre-op in the learning process? Do they go to the class? And do they have a good primary care provider? The surgical experience and then the surgical team factors, particularly anesthesia, very important. And then the therapy services afterwards, are they aggressive? We try to get people up the same day and make sure that they have aggressive therapy right after surgery. So when we looked at the documentation of it, we thought that, and CMS told us they were going to look at the history and physical pre-op, the discharge summaries, the operative notes, things like that. They didn't do that. They weren't able to figure that out because they couldn't read the notes. So instead, they use claims data. And what they do is they look at data from the primary care orthopedic practice 90 days before the index procedure, not the op notes, nothing else they told us they were going to do. And they try to document the comorbidity and risk adjustment factor. But they did this after they rolled the plan out without telling us. And so we didn't document it. So now moving forward, it's really important for everybody to know in this call to make sure in your EHR under problems and diagnoses or whatever your EHR is, that you're documenting the medical comorbidities way ahead of time in ICD-10 coding fashion. And that's that huge list I gave that some of the things qualify for it, but if there's consistent documentation, that's very, very important because it increases the risk adjustment factor. So if someone gets readmitted to the hospital, you don't get a big ding for that every time. And so you're also not cherry picking and you're not just taking healthy patients to the OR constantly. So if we looked at the patients in our population, we noticed that the number of hip fractures are increasing slightly over time, that we're seeing that from left to right here, that the bar keeps on going up for hip fractures over time. And what we're noticing is that those patients are living longer and they're sicker and sicker. And the question is, with these inpatients now, and that includes hip replacements, hip fractures, and non-operative treatment, how do you look at these patients? How do you triage those patients? How do you put them in an acute setting now, not a chronic setting, and document their comorbidities, plus recognize when they come in, how to handle them and get them ready for the operating room? These trauma patients, they're essentially geriatric trauma patients. When you triage these patients, they can be stat patients. So a patient has a limb or life-threatening issue, they got to be in the OR within about 2 hours or so before they have things like compartment syndrome or bleeding or lactic acidosis. Is an urgent patient. A long bone fracture will create blood loss. Those are things that we want to avoid, bleeding a lot in an older person or any person. And for those patients, sometimes we give things like tranexamic acid, which is different than Lovenox as a blood thinner. Some of these patients are getting admitted and they're put on blood thinners right away and they bleed down before surgery. And we've contraindicated that now and said, no, actually do the opposite. When someone's at risk of bleeding, you give them tranexamic acid, which prevents them from riding their blood pressure down and having a really bad surgical experience. So skin tenting can kill the skin. And then semi-urgent chronic hip fracture, or things that are, hip fracture wise, can be done at about 24 to 48 hours. The patient that way can be hydrated and triaged accordingly, get things like an echocardiogram or worked up before going to the OR. So when you're asking acute versus chronic tuning, so that's in more of an acute recognition, the hip fracture, job one is to get them to the operating room within about a day or so. And then looking and seeing if they have things like reversible comorbidities and which things can you reverse in 24 hours, which things will have the biggest impact. The things that will have the biggest impact that will lead to pneumonia or pressure sore or things like sleep apnea, poor hydration, because when you put the spinal in, they drop their blood pressure and they tank and have a stroke or something. Chronic anticoagulation's got to be reversed. Poor cardiac function, low ejection fraction, aortic stenosis, peripheral vascular disease. Do they have a bad cardiac pump? Do we have to supplement that? Do we have to put them on medication? Do they have to have something else like an aortic balloon preoperatively? And essentially, do they have stiff arteries? Or is their pressure going to go up and down during surgery and they risk a stroke? So you have to look at those things ahead of time and try to mitigate that. Do they have a AAA? Do they have calcified vessels, COPD? Patient this week had elective surgery during the week and didn't tell everybody that she was smoking chronically, and she didn't quit smoking, and she wound up getting pneumonia right after surgery due to COPD. Chronic narcotic and drug dependency. We start to reverse those medications about a month ahead of time when possible, because we found that the chronic narcotic and drug issues will actually lead to higher revision rates, because patients show up and say they're still in pain afterwards, and there's really nothing wrong with them. They're just kind of used to saying they're in pain. And we talked about diabetes and poor nutrition and the aspiration risk. Those are things that we have on our list of hip fracture triage to try to mitigate prior to surgery. And that's why we kind of give them at least 24 hours. We have a hip fracture flow sheet, and this is good for all geriatric fractures, and it's designed to decrease delirium. So when patients have delirium and they're given narcotics like morphine in the ER or the ambulance, they lose control of their airway. They have other issues and they start to lose their minds. They go into delirium. So they can't protect their airway. And that's what leads to pneumonia and other issues. So we've developed a Dominican, a whole flow for each phase of care that minimizes the narcotics and improves the ambulatory issues and gets them out of bed a lot faster. And so we go through this checklist that we've developed in the hospital with the nurses and try to avoid narcotics. In Australia and New Zealand, they've stopped giving narcotics in the ambulance. They give a regional anesthetic. So our patients who come with geriatric fractures in the ER get a regional block in the ER to avoid IV morphine and other issues. And we did this just last evening. We had a patient admitted that we did that with. So hydration is very important. Aspiration precautions. We put compression stockings on their legs, get rid of the delirium risk factors, get a block as quickly as possible. And we consider echocardiograms in these patients also if they have a poorly known cardiac history to make sure we're not putting a spinal in a patient with aortic stenosis. We use as much local as we can. And then afterwards, multimodal pain control. What does that mean? We use things like gabapentin, tramadol, and Tylenol, and then we use narcotics as a last measure. The European studies show that Americans use way too many narcotics for fractures. Europe mostly uses non-steroidal medication and Tylenol, and we use these other medications to try to mitigate the narcotic uses I just talked about. But in the US, our narcotic use is off the charts compared to the rest of the world. They don't use anywhere near as narcotics as we do. And we've demonstrated that these medications work well for these patients because postoperatively, when they are getting narcotics and we start these medications, when there's a doctor who doesn't know about it or the patient's refusing to do that, their pain changes drastically and their function improves quite a bit. So we've noticed that things like Neurontin and Tramadol, particularly Neurontin, will reduce narcotic usage by 30%. And only about 17% of people will ask for pain medication at 2 weeks post-op with hip fractures and with elective joint replacements. And that reflects on better surgery, but also, frankly, better medication. So in the elective tune-ups, the things that we're looking for, I wrote a couple of papers on this and outlined it as we've talked about a little bit. And then also the most important ones that I'll just go over again are a body mass index over 40. I send people for weight loss coaching and dietary consultation. Low vitamin D levels, we want them universally to be above 50. And then hemoglobin A1C, we want them to be about 7 or less. When it starts to go up above 7, you increase your wound healing complication rate. Albumins below 3.5 can tend to lead to poor wound healing. MRSA colonization is an issue, and then sleep apnea. So these are the 6 major things that we look at perioperatively. So we want to make sure that they're in line for that kind of stuff, and then that reduces their risk factors substantially out of those 70 things that we listed. The elective situation preoperatively, when patients are smoking cigarettes or marijuana, we ask you to stop at 2 weeks pre-op. Nicotine gum makes things worse. We also take narcotic usage pre-op and swap them for tramadol and gabapentin when possible. Sometimes we use clonidine patches. It makes the pain medication more aware and more available to their brainstem. And then, like we talked about, regional anesthesia as much as possible. We found narcotic use goes way down with this process. It helps a lot. Hep C's got to be treated electively. Renal failure is non-operative. We can't do total joints in those patients. They don't heal. And the TNF inhibitors from rheumatoid disease, we stop 2 weeks ahead of time. And then catastrophic thinking is a major cause of postoperative poor outcome in all of these issues. So what we look at is that the patients in hand surgery and foot and ankle and total joint replacement all have this issue. And it has to do sometimes with work comp claims. So if you look at work comp claims, these patients are classic catastrophic thinking patients. We try to pick that up in the pre-op class, and I canceled the patient this Tuesday because I thought she was in that category and had her seen by a psychologist or psychiatrist. And I'm not sure she'll ever go back on the OR schedule, but she was canceled for that reason. So in the elective cases, we also look at the anticoagulation. Heavy anticoagulants can lead to wound healing issues. And so that those patients ahead of time, they're stopped accordingly. We may use a vacuum or something post-op. We also want to know why they're anticoagulated. So we look at the list of issues and kind of treat them a little bit differently every time. Some people need bridge therapy if they have an artificial valve, and some people can just stop the anticoagulant and they're okay if they've had a history of something else. So we consult with the cardiologist, and we also talk to the family medicine doctor and try to figure out why they're on that blood thinner to begin with. The other blood thinners that we don't even know about, things like herbals like ginkgo, fish oil, vitamin E, stuff like that. And when they're combined with these other normal blood thinners, they can bleed out, and they're hard to reverse those blood thinners. So in every patient, they get tranexamic acid pre-op, which stops them from bleeding on general. stops wound healing issues, but also needing for transfusion. The risk stratification, we use cardiology to do that. When someone falls into ASA 3 or higher, we ask for cardiology consults a lot because it makes anesthesia a lot more comfortable and prevents cancellations. We have a really low cancellation rate. We have a cardiologist in our office in Capitola every Tuesday who helps to look at our higher risk patients and get them through the surgery so they're tuned ahead of time, but also so that the anesthesiologist feels comfortable and knows where they can take that patient during surgery. Because basically anesthesia is a physiology experiment. And we want to make sure the anesthesiologist feels comfortable and the patient does well. So the practical side of cancellations is it leaves a lot of wasted resources. So the OR has block times. We have, a prep time for a 1 hour total joint replacement can be years to months. One of the patients I did yesterday, I've been pre-oping for 15 years. I've been taking care of her knee for 15 years to get her ready for surgery. Everybody else is anywhere between 6 months and a month, 3 months, 4 months, things like that, or a couple of years. Each cancellation affects about 25 lives. Our staff, the patient's family, their work, the insurance authorizations, the surgical equipment we've flown in sometimes all over the United States to be ready for a 30-minute case. That's very expensive. And then the opportunity cost to another patient who can't have surgery or the healthcare system. So the pre-op tuning is really important to get the diagnosis right. That involves things like injections, x-rays, and MRIs. And then looking at our patient-reported outcomes data is very important to look at when they drop below a certain range to decide about surgery. So the things that we look at post-op when patients are managed post-op in the hospital is that if someone has a low-grade temperature, it doesn't necessarily always need to be worked up. We look at the classic things like wind, wound, water, walk, and wonder drug. Not everybody with a post-op fever for the first week needs a chest x-ray, blood work, and urinalysis. We don't do that routinely for most of our total joint patients or patients with big surgery. We get them up and walk them, we hydrate them, and they generally, their fevers go away. We also got to be really careful not to over anticoagulate them. Everybody who gets readmitted for an event will wind up getting a ton of anticoagulants unless the hospitalist is told not to do that. And it results in a really high perioperative infection rate. So we try to avoid that as much as possible. So conservative care for total joints is weight loss, like we talked about, a BMI of like 30 to 35. We want to get their weight down that range. Every time they lose a pound, we remind them their legs feel like they lost 3 pounds. Because when you walk, you put 3 times your body weight across your joint. When you look at these patients, we've done things like all of these injections that we have on the screen, things that are experimental still are stem cells, PRP. For hip is experimental, but for the knee, we've got orthopedic evidence now for platelet plasma that it makes a difference for arthritis. It was experimental, but now we've got the first FDA studies that show efficacy for knee arthritis. There are different types of stem cells. I can go through that anytime you want. I was a stem cell researcher at the National Institutes of Health, so I'm happy to talk to anybody about it in details if they want to. When people have pain, it's a night pain. It could be a rest pain. It's startup stiffness, and we want to get them before they fall. A lot of patients will fall and break something because their leg gives out on them, and we want to avoid that. And that's consists of the conservative care, physical therapy, and injections. And the things in most joints rank the highest is corticosteroid, PT, and weight loss. Those are the 3 most important things to maintain mobility and independence. And so you look at this x-ray, for instance, this x-ray for the hip, this is pretty reasonable. It's a little bit narrow. The left one is bone on bone. So we've taken a computer digital template and mapped that out prior to surgery before we go in the operating room to make sure all these angles are appropriate before we go in there, that the leg length will be okay. We know what the shortening and the leg length is ahead of time, and we document the joint narrowing and things like that. So to decrease complications, we have people go to the pre-op classes, get educated. We make sure we have the regional stuff we talked about. I use an anterior approach for the hip replacements, less invasive, partial joint replacements. We have specialized therapists, nurses, nurse navigators, get people up right away. And we use specialized home health nursing. And then the question is, with all this stuff, is this theoretical or hypothetical? How do we do? Well, we went back and looked at our data. This is how we did. So when we look at the patients over 5 years initially from starting the program in the early 2011 up till 2015, these numbers on the left were the early numbers. So patients who had early mobilization were factors interfering with their ability to get out of bed right away. There were multiple factors interfering with their ability to get out of bed right away: nausea, severe pain, low blood pressure, and motor and sensory impairment. Most of this had to do with a lack of hydration and bad anesthetics. So as we got up to 2015, now we're down to 1.8% interference of all these factors and 0.4%, because we're giving preemptive issues and really emphasizing regional anesthetics and other techniques to minimize nausea, pain, and hypotension. And that's why patients are getting up the same day. We made a big progress. Also, sending people home as opposed to skilled nursing facility and getting them out the door. 2011, 45% of people were going to a skilled nursing facility. In 2016, we were up to about 87 to 90%. And this is about the ceiling where we hit every year after that. It's hard to get above 90% in our patient population, and it's totally dependent regionally. A lot of these people don't have family in the area. How do we do with severe pain limiting mobility? 2011 was 40%. In 2016, it's down around less than 1%. So it really makes a big difference. And then the total hip performance trends, if we look people going home as opposed to going to a nursing facility, 95% by 2020. Day two, up to 80%, 87%. And day one, 67%. Now, the most recent ones in 2021, we sent everybody home today at day one. Post-op, we did 6 yesterday, everybody went home. So we've decreased utilization substantially. And you say, hey, maybe you're filtering things out. You're taking care of the health of your patients. Our ASA 3 and 4 levels climbed up to 2019, and they stayed about the same in 2020. So we're actually taking care of sicker patients at this point. Same thing for total knee. People are going home much faster, and they're just doing better in general. When you look at what helped a lot, when you look at total knees, for instance, in the Australian registry data, at about 2 years afterwards, about 83% of people were happy with their knees when it's done in a conventional fashion. Almost 18% are unhappy because of loosening. Not loosening per se. Their knee feels loose and unstable. It doesn't feel good to them. So when you add a robot in, the outcome at 1 year plus to 2 years, when we do robotic knee replacement, really helps a lot, is 96% satisfaction versus 81%. So things like robotics have helped, anterior approach has helped, regional anesthesias have helped. It all adds up a little bit at a time, and it's equal to the sum of the parts is greater than the individual pieces. So the importances of this is that quality is important. It involves sorting patient comorbidity. Not all fevers need to be worked up. They're not all infections. Reversing comorbidities are very important in the acute phase as well as the chronic phase. And many of them we're finding are undertreated pre-op. There's a lot of rush pre-op to treat things that should have been treated all along. Patients are not always operative candidates because they have chronic issues that can't be addressed. And this isn't just a one-time prep for surgery. It really ought to be a continuum or management of these disease processes on a chronic basis. That's the principle of the ACO and epidemiology that we're taught in training. And the process involves complete teamwork and understanding that there's leadership from the physician side and that consultants who come in to help us are not stakeholders. We are. We own this thing. That's why we own the bundle. And that's why it's really, really important that we understand the details, and every little thing that we do makes a difference to a patient. They're not generic and each person's individual, but you can combine aggregate data in order to affect everybody that you take care of. That's the idea behind all these processes. So thank you very much. I'll end there, and we can take some time for questions right now if there are any questions.
Thank you, Dr. Abidi. We are going to dive into Q&A session. Please direct your questions by using Q&A button at the bottom of your screen. I'm going to mute myself, and the panelists can address those questions.
Yep. So I'm not seeing anything on the line right now, so I'm going to start off by asking some folks some questions. So if you guys are near your microphones and I can't see all the participants there, perhaps you can unmute yourself when I ask you a question here. So Jeff, that was an amazing lecture. It's a phenomenal medical student resident, attending lecture. Very good job. I really appreciate that a lot. Very well organized. So you really liked the Steph, I guess, or you didn't like Steph so much, right?
The names have been changed maybe to protect the patients.
I love it. Yeah. So except for that Jersey patient, right? So got back from Jersey 48 hours ago. So I understand what you're talking about. So when you look at primary care in the office, what percentage of your primary care sports medicine practice is primary care, chronic treatment versus sports medicine in the office in the setting that you're in now?
So traditionally it's been about 50-50. And I kind of kept it that way because I really get kind of bored if I see too much family medicine, and I kind of get a little bit bored if I get to see too much sports medicine. I kind of miss the family medicine as well. So it's been about 50-50. Interesting that as I get older, I've had patients for a while that have been with me for a long time. So I probably do a little bit more family medicine now just because of the patient base, but I really enjoy both. And I want to keep it that way.
So I noticed in California, that's different than the rest of the country is that not a lot of people have primary care docs. I'm not sure if that's changing nationally. I know in Philadelphia that you're always tied to your doctor since the time you're a kid till you get older, until they retire, or you need another doctor if you move. But I think that the importance of preventative care, which used to be part of health maintenance organizations, kind of gone away. Is that true? Or do you still have benchmarks that you look at for people when they're 20, 25, 30, 35 by the American College of Physicians or American College of Family Medicine or personal guidelines? How do you look at those primary care patients? Do you see them routinely or do you get lab work routinely? When do you do some of those things?
So I try to order labs at least baseline on people. Most of the guidelines are you don't have to check labs on younger patients, say 18, 20, or 21. I've seen a lot more abnormal labs in people that are younger, and I think it's just that people are fatter and in worse shape. And probably the scourge of our society is metabolic syndrome, and that's essentially occurs in everybody kind of starting about 40, but it is occurring in much younger people. Also the South Asian population has a ton of metabolic syndrome. So I like to screen for that early, and I think you can pick things up early. And there's sneaky things that you can look for in the labs that may not be flagged as abnormal, because that's all patients care about when they see their lab results. They just look down and see what's red, and they want to say, what can I do to fix that? But there's things that will sneak up, like a fatty liver with an ALT elevation, or triglycerides. Normally the lab says under 150. I think they should be under 100. So things like that will creep up, and you can see it creep up if you see the patient each year and check.
Yeah, and we see that perioperatively on in patients where they said they weren't diabetic. And I canceled someone this week who had a big procedure coming up, and he's definitely diabetic. And so what we see that's really important orthopedically is some pain isn't always due to an orthopedic issue, as you said. So I had this patient I did a total ankle on about 7 years ago, and he came to see me a couple months ago, and he wants to have that cleaned out or have it looked at or something like that. And I said, if you don't mind, I'm going to get a systemic inflammatory workup to see if your body's changed. And indeed, he has gout, and his A1C was 10.6. And so he denied having diabetes or anything else. And the joint looked great. Everything else looked good in his body. But, he had diabetes, and no one had screened him for that because they thought it wasn't important because he's 46. So, that's an issue. And I asked him about his family history, and he denied all that stuff. But lo and behold, he's pretty sick, actually. And so we'll see that once in a while, and that can result in a surgical catastrophe. So I know when I see young people who fit the profile of what you're talking about, I send them to you. And I really appreciate that you understand that care. And anyway, that's kind of, it's really important in medicine to understand that you're kind of a scientist first, and that you're working on these things along the way to make things better and really take care of patients. That relationship is really important. So let me go on to, let's see, Rocky. Rocky has a question here. So Rocky says, great presentation. Very fortunate to have OrthoNorCal in his community. Rocky, thanks. We're fortunate to have you too. As a movement specialist, he encourages his colleagues to refer to orthopedists in the community. How does he encourage colleagues to refer to orthopedists in the community? More importantly, how does a fitness professional decide which orthopedist to refer to? After all, it's called a medical practice, not medical perfection. And there's a wide spectrum of doctors in orthopedics. And how do you tell how all those doctors are exemplary compared to simply with the minimal requirements to earn a degree? So Rocky, good question. So an orthopedic surgeon has to go through 4 years of medical school, 5 years of residency, and frequently do fellowships, and then be American Board of Orthopedic Surgery certified. That doesn't make them all super wizards. Some of it is really up to what we look at is patient referral base. Patients are satisfied, or also the primary care interaction, your primary care doctor's interaction with that orthopedic surgeon. So there is currently no objective ranking to look at an orthopedic surgeon's outcomes, like looking at the gauges on your car. However, insurance companies do track those things. So we talked about quality measures tonight, and actually I post all my quality measures online for that reason, because as you said, we're not perfect, and we know we're not perfect because our data, when you publish data on all of our procedures, are about 85 to 90% good or excellent. No one has 100% perfect or good outcomes. It just doesn't exist. So you have to take people who've been in the community for a while, are board certified, and have a fellowship or have experience in that area. That's generally what we're seeing, and that's the degree that you can make an assessment at this point. So there's no real, true objective way of looking at people individually. It's got to be a little bit more subjective. Jeff, you're a master arbiter of referral to orthopedic surgeons. Is that about right, or do you have anything else you want to add to that?
I think it's a great question, and I think you need to go back and think like a patient. Patients end up asking their family members who they should see, and they hear that, hey, Uncle Joe had hip surgery with this person, they had a good outcome, so I'm going to go to that doctor. To me, it's amazing the number of people that actually have predetermined who they want to see. I think ask around, when I first moved here, I didn't know who the good doctors were. And so I went to the hospital administration and I said, who do you guys see? Who has the best outcomes? Ask the physical therapist. If physical therapists know who has bad outcomes, who gets infections, who has to go back to the operating room. It's hard to look at reviews. I think reviews kind of tend to review the staff, how nice the office person is, how nice the doctor is. Maybe they're a cruddy doctor. It's not an easy answer. There's a lot going into it, but I think you should ask around and get a few different opinions from different sources. Those are just some of the ones I would typically go to.
Yeah, that's a good point. Those are things that we think about quality measures that as we're practicing, but that's what the public does see. All right, and that's the kind of what we're driving at here. Some of those things like quality measures, bundled payment, looks at readmission rates, and looks at complications. And the insurance companies actually do rank and they do adjust us now by looking at that. So they have both utilization review as well as quality review for that reason. United Healthcare, Cigna, Aetna, and Blue Cross Blue Shield especially look at those things. So
you know what they would do? Like they would ask Tina and say, Tina, who would you go to get your back surgery?
Yeah, what's really shocking is I had today, I have Google and Apple people every day. And I asked the Google guy today who I took care of, I said, so why did you come to see me? And I know that he trained at Pitt, he went to Carnegie Mellon, stuff like that, and works at Google. So he has access to everything. And he didn't Google me, but I'd taken care of his wife. He didn't realize that I'd written all the research papers about what he had. Even it's available widely on Google, and he himself did not Google all my papers, which was really shocking. It's just because I did a good job with his wife. And that generally is that patient-to-patient contact, and that experience seems to be the best thing. And unfortunately, it's not objective. All right, Tina, so let me ask you a question. So you're sitting back there. Thank you very much for your pain algorithm that you brought up in your treatment algorithm. Let me ask you, so if you have someone who comes in, 25-year-old person with low back pain for the first time, do you get back x-rays on that person, or how should the primary care doctor, how should the PAs or the nurses listening to this conversation, how should they handle that first-time back pain patient who doesn't have any pain shooting down into their legs?
As I stated in my presentation, it's all about history, and then physical exam. I listen to the patient, I figure out the mechanism of the injury. If it's only axial and not radiating, most likely in a young person, it's discogenic problems. If it's a lifting or bending over kind of problem, once again on exam, if it hurts more with flexion, less with extension, it's more like discogenic. And has that person gone through conservative treatment with physical therapy? Have they tried non-steroidal anti-inflammatories and that's failing? Are they able to function? Are they able to go to work? And if they're not, then, if it's excruciating back, well, maybe I will some x-rays and make sure that there's no spondylolisthesis slipping going on. But, in the primary care setting, you're typically not going to order an x-ray unless someone has, say for, 6 weeks, let it go. But if they're not able to function, they're not able to work, and you've tried an oral steroid dose pack, they're not able to participate in physical therapy, then, maybe it is time to start getting some imaging on them and make sure that there's not something that's.
So let me ask you then, I'll ask you the question is, who would you be contraindicated to getting a film in the first 6 weeks? Who do you try not to radiate early on? What age groups? What
Absolutely. I try not, I rarely see 20-year-olds, to be honest with you. That age, I typically start seeing disc herniations more often in the 30s, 30s, 40s, 50s, less often 20s, occasionally very rarely in their teens. Certainly won't image a teenage, well, I want to back that up. If it's a teenage athlete or a young 20-year-old athlete that does a lot of extension, baseball throwers, gymnasts, volleyball players, then I got to worry about, is there a fracture, a pars fracture resulting in a spondy. So it's, once again, it's all about the history and their mechanism of their injury, and then how bad the pain is.
Right, that's great. That's what I was asking. In terms of what we see a lot that we really worry about is actually spondylolisthesis from hyperextension injuries. So linemen in football, gymnasts from hyperextension are classically what I see. And I will image those kids. So I've had people with, soccer injuries getting hyperextension kind of things. So they have tight hamstrings, on the supine exam, and all of a sudden they got back pain with hyperextension. And we've usually picked up wacky things. So we've seen things that just really shouldn't exist in 14 and 15-year-olds, like herniated discs or a compression fracture. and spondy is definitely understood. Some of that's congenital and some of that is acquired. So pars defect can be congenital or it can be, acquired. And it was spondylolisthesis was discovered by an OBGYN, during deliveries for anterior listhesis during, it was discovered by OBGYN. So, it's just a congenital thing in some folks. So that's phenomenal. So your algorithm involves, non-operative. We talked about steroids, physical therapy, stretching the hamstrings, going to PT. And then you do epidural steroids. How often, and how often do you do focal injections?
Focal injections, are you talking about trigger point injections?
No, intradiscal or facet injections.
I don't do any intradiscal. I never have. There's a lot of controversy about discograms themselves.
Right.
So in my young folks, my 20, 30, 40-year-olds, it's statistically almost always a disc problem. And epidurals are primarily used for radicular symptoms. They're not great for just axial low back pain, unless that axial back pain is due to spondylolisthesis. Okay. And I work really closely with my surgeons because that's where a lot of my referrals come from, or my spine surgeons too. So a lot of the time they're trying to figure out if that spondylolisthesis is causing that axial back pain versus the facet joints. So we may start with an epidural, see if that spondy gets better with the steroids. And if not, then they may have me target the facet joints with medial branch blocks and eventually radiofrequency ablation.
Right. So one thing I've noticed is that, and I see this all the time in the reviewers who move from East Coast to West Coast or look at our algorithms. And my dad's a neurologist on the East Coast, and I trained in a spinal cord trauma center. So our surgical rates were much higher there. And in California, when they look at our data sets from Medicare and insurance companies, they actually like everything you do. Is non-operative management, is a screening tool, localizing things. And frankly, most axial back pain is non-surgical. It's, unless you have a spondy. So can you talk about the difference briefly about a younger person having a disc versus an older person having facet hypertrophy and having stenosis from the back of the spine to the front of the spine? That's really hard to get rid of with conservative care. When do you decide that conservative care is going to give up or it's not going to work when you got bony facet hypertrophy or a bony, restriction anteriorly versus a younger person who's got a disc?
I love when I get the young engineer. I used to work really close with a lot more engineers, and because they sit all day, get a lot of acute disc herniations and radicular symptoms. And I loved those patients because they got better with one injection, right? One and done, or maybe two, they're good. But the older folks, they're my favorite population because they just want to be able to go to their daughter's granddaughter's wedding, right? But they come back, they have more bony, like you said, foraminal stenosis or central canal stenosis. And often I can get them relieved enough pain for 4, 6 months or a year even with an epidural steroid injection, and they can avoid surgery, which I think we need to educate the older populace that they don't necessarily have to live with chronic low back pain, that these epidural injections can provide them more function, and they don't necessarily have to have surgery.
So that's exactly what I wanted to hear about is that. And so let me ask you one more thing that I'm not sure if you talk about in your talk or not, but how do you distinguish between neurogenic claudication and vascular claudication when you're talking to the patient, besides pulses? Because their pulses can be inconsistent with AFib. Yeah. And when they get to ambulate, they may have aortic stenosis, or they may have, calcified aorta or iliac stenosis. But it's hard sometimes to get that neurogenic question out. And when I teach medical students this, as I used to be the director of medical education for medical students, and I want them to distinguish between those two things. How do you do that?
So vascular claudication is very similar in symptoms. Is that when the patient walks, they get increased pressure in their back and some pain that goes down their leg. Now with vascular, when they sit down, that pain goes away really quickly. But the neurogenic claudication, it lingers a little bit longer. You could also ask the patient about does you have pain when you go uphill? And when they have neurogenic, correct me if I'm wrong, it's been a while, but if they go uphill, they get pain faster going uphill. The neurogenic does. So I often ask about how long you can walk, and then if you sit down, does it go away right away? And that's the key. That's
one of the things I ask them about is when they go shopping, do they do better with the shopping cart? Yes. If they do better with the shopping cart, that's neurogenic claudication, not vascular. And that's the uphill thing you're talking about, actually. Yes. So anyway, that's kind of what I always ask that question about the shopping cart. I just remember that one. So I just tell the medical students, the PAs that are online, Hoppenfeld's textbook, the Green Book, it's good for physical diagnosis and anatomy, and really important to look at dermatomes. I look at the foot drop, and I look at reasons for foot drop with tibialis anterior tendon rupture, perineal nerve issues, and I look at spinal cord issues as well. So I see people for foot drop all the time, and I'll see all 3 different varieties in 1 hour, or something like Charcot-Marie tooth disease. So the spectrum of neurological issues is really important that you keep examining their legs, you keep talking to them. Whether or not they're there to talk to you for that reason, you as trainees or younger people or PAs and nurse practitioners, look at their legs and keep doing it, even if they're not talking about that, because eventually you'll figure out what we're talking about. And the only way you'll do that is by examining as many humans as you can, normal and abnormal. You'll get a feel for it eventually.
Yeah.
So that's really, really important. Jeff, do you have anything to add to that I missed from your perspective as you're sitting there?
I think the back is very tricky. In fact, in sports medicine, that's the #1 thing we see is back pain. I think that's just across the board. That seems to be the most common complaint for most people. So I think Tina's going to be busy the rest of her life, certainly with back problems, especially with the fact that everybody sits. But I think one of the points you guys talked about earlier was who to x-ray. And I think we're taught in medical school sort of like the really young, under 20, and the really old, over 60. When they suddenly get back pain, that should be sort of like a red flag. Typically you get it maybe in your 30s or 40s, but I like to x-ray all young people because there really is no reason why a young person should have back pain. And there a lot of times is pathology there. And I think if you can kind of get it early, I think it's really important. And if nothing else, it can calm the parents down, and you can get the patient to take it seriously and get on a good program and say, hey, look, whatever you're doing, you're playing tennis 8 days a week, you're swimming for 4 hours every day. This is not great for your back. You need to kind of do something a little different and change your training. I like to x-ray all people under 20. And I think that's kind of my rule of thumb, unless it just looks like a strain.
Right. So the thing that we try not to radiate little kids, but today I'll see anywhere from peds. So I do a scoliosis exam on every little kid that comes in because the schools aren't screening them enough. And today I had a toe walker, for instance, and he didn't have scoliosis, but we look for things like syrinx and tethered cord syndrome or Chiari malformation. So those kids can have back pain at a really young age, and they can have an advanced scoliosis, not idiopathic, at a very young age because of a neurological issue. So x-raying them, certainly with any deformity, is very important. But I would generally do a screening, AP and a lateral. I won't do the 5 views, and I won't do the flexion extension views unless I see something wrong there, or if we're considering surgical intervention or instability due to spondylolisthesis, facet insufficiency, or a pars defect or post-traumatic. So, looking at compression fracture versus a burst fracture, things like that, I'll get more advanced x-rays in those cases. That's generally for spinal cord training or spinal cord. When we wrote the algorithm for that by Dr. Rothman, who trained me, and Sam Weasel, basically that's kind of what we're looking at. Is it an instability issue? Have they had pain for more than 6 weeks? Things like that. And especially if they have a neurological finding, you got to get a film and work it up. So Clay Christensen's asking a question here. Clay says, can we talk about the role of vitamin D in fracture care and perioperative management and osteoporosis screening in elderly population? So Clay, a great question. I would say that that's not even an older population issue. That's an every population issue. We're finding that even in California, and I have patients from Hawaii with really remarkably low vitamin D levels. And it can correlate with other things too, like the compromised immune system, poor healing, certainly with fracture metabolism. It has to do with incorporation of the calcium and basically the ability to ossify osteoid material or collagen that's put out by osteoblasts, very important. And it has a lot to do with your renal function as well as your digestive capability for absorption. So people who have gastric bypass, for instance, don't absorb things very well at all. They have a real problem with many, many things. But when people have vitamin D deficiency, they're not actually absorbing calcium or incorporating into their bone system very well. And there's dihydroxy and there's trihydroxy vitamin D. So it's hydroxylated by the renal system. There's a monograph written by Fred Kaplan. It's a Sivagagi monograph, and it outlines all of those issues. And that was written when he was a professor at Penn when we were there. It's a very easy to read monograph about vitamin D. And what we're finding is people are pretty low. And at our national level, at our meetings, at international meetings, when we actually presented the data, everybody raised their hands and said 50 is what they look for healing process perioperatively. So that's very, very important. We're seeing it's low in older people and younger people. As far as osteoporosis goes, that's a multifold question. That's a huge lecture. I'd leave that for another day right now. So Jeff, what are you guys seeing with vitamin D? And Tina, what are you seeing with vitamin D issues right now? And how are you treating it?
Absolutely. I have been screening people for vitamin D for many, many years. And I think osteoporosis doesn't need to be a disease that you treat. I think it's a disease that you need to prevent.
Yep.
So you only build bone until you're about 30. And
Right.
I have given lectures to schools, kids, middle school age kids, that they need to, and adding on to your point about vitamin D, is the soil is depleted. You can eat as much leafy green vegetables as you want, but the farmers have used that land for so long that a lot of the vitamin D, even in the organic lettuces, are less used to be. So highly, highly encourage parents to supplement their kids on vitamin D so they build stronger bone to prevent osteoporosis later in life.
Yeah, you're 100,000,000% correct. I did a fellowship in osteoporosis at NIH, and we looked at long-range data in Sweden and the rest of the world with the World Health Organization before we chose DEXA scans. As a screening, we were doing phantom CT scans. Problem is, there's too much radiation. So DEXA scans are notoriously inaccurate. All of these things are really, really reactive. And you're right, you got till age 30. And what we're seeing in the American population is sodas, diet sodas, smoking, all of these things add up, including genetic history. And preventing it is a big deal because none of the medicines really make good bone. Not the parathyroid hormone meds, nothing. And bisphosphonates make terrible bone. You know, it's osteomalacia almost. So preventing it is the key, and treating it, after, it's kind of like we're catching up now. And that's supposed to be a quality marker for orthopedics, is own the bone. It was a campaign about 6 years ago. It just is not getting enough traction. I check vitamin D levels and A1Cs in all my perioperative patients, and to make sure that we don't get surprises, because I hate treating things afterwards metabolically, especially the fusions and the fractures that we take care of. It's really easy to prevent that. So is that what you're seeing, Jeff?
So I used to check vitamin D levels on everybody. It ends up being a very expensive test, and some insurances don't pay for it with a physical exam. Interestingly, I think LabCorp or Quest will charge the patient $290 for a vitamin D test, and then they all get mad at me. So I leave it off unless someone asks for it now. But to be honest with you, I'm actually surprised when one comes back normal and they're not supplementing. Pretty much everybody's low in vitamin D. We target between 40 and 60. I think that's normal. So your 50 is right on. The general guidelines, I think, are a little bit low in terms of what they recommend. They recommend 2,000 units for people maybe under 20 with vitamin D. We put everybody under 30 on 5,000 units of D3. And I think I've not seen anybody with vitamin D toxicity other than a couple of strange patients who decide to take 10 or 20 units a day. But it's, I think to be between 40 and 60 is a good target. Also, Nick, vitamin D is part of the COVID-19 treatment before some drugs. It's certainly been shown epidemiologically to help prevent, COVID as well, COVID infection, and also nastier COVID infection. So I think vitamin D is a great overlooked.
Yeah,
vitamin.
thanks. That's phenomenal. I think that my vitamin D level was like 38. So I started taking 5,000 units last year. Luckily, Beth's, when we tested, it was around 50 or so. So, ironically, there are some people contain level, reasons that are clear to us. Our diets are the same household, same everything. And she's out in the sun less than I am. So what you're saying is, it really, there's a lot of underlooked and preventable things. My only conclusion in that was that basically vitamin D wasn't patentable by a drug company. Therefore, the large, when we were at NIH, I was looking at estrogen receptors and bisphosphonates and parathyroid hormone fragments and growth factors and crazy stuff like that, because the companies were driving that stuff. Whereas we didn't look at vitamin D in the 80s. That was so stupid of us not to look at that material. It's a really key step.
Just a couple other things, Nick. We're all scared of the sun now, so we all wear hats and sunscreen. Even when people go outside, they go out and maybe their face and their arms are exposed. It's really about surface area. You need to be out there probably in a bathing suit. And I don't think anybody does that because of skin cancer. So, I think nobody's really in the sun. The other thing is, don't forget vitamin D. When you do prescribe it, it's one of the fat-soluble vitamins, ADEK, A-D-E-K, the fat-soluble vitamins. If you just wake up, have a glass of water, and take your vitamin D, you can absorb it. So make sure your patients take it with a meal. Some vitamin D is actually packed in olive oil, so it can actually help with the absorption.
Awesome.
So just a couple.
Yeah, we knew about A, D, E, and K. Okay, so unless there's any other questions from the studio audience or the speakers have anything to say, thank you very much for a wonderful evening. I learned a lot from everybody. I really appreciate your time. I think this is wonderful. This is a recorded webinar, and let me just ask Leah. Leah, where is this going to be available later? How will this be available to people?
So I think it won't be available to public. The recording will be available only to those who joined today. If you would like to request the copy of the recording today's CME course, you can email us at info@orthonorcal.com, and you will be provided with the private link to watch the webinar over again. And the guidelines on how to obtain your CME credits will be emailed to all participants as well within the 24 hours. So just follow the either QR code or the link to submit all the information that will be asked to the doctor's company to receive your 2 credits. And thank you everyone for joining us today. This was great. And thank you to all presenters. I personally learned a lot, so I very much enjoyed it. Thank you.
Please fill out your evaluations and get your CME credit, please. We absolutely love that we can do this. We really thank the doctor's company, and I really love my colleagues for joining me again. It's fantastic. I'm a privilege to practice these guys. So thanks again, and I look forward to seeing you guys at work. Take care.
Thank you, everybody.
Thank you. Good night.
Good night.